So PNR204, week 6, guys. We're going pretty quick. So this week, we're going to be doing respiratory and cardiac, and I'm going to do it in a cahoots. I went through and re-updated it, looked at it, see what I needed to do for it. And I think what I have there is exactly what you need. Remember that you do have a CJ Sims. They are worth a lot of points. They're 5% each. So do not ever miss the CJ Sims, okay? And if you do miss it the first week, I'll tell you, please get it in. It will affect your grade either way, okay? So CJ Sims, get it done. And of course, we had our exam, and we're going to go over our cardiac respiratory. So let's go ahead. I know most of you have not looked at cardiac respiratory. You've been studying like crazy. So let me see if I can get you to understand it just through a cahoots. I do this a lot after exams, and I think it works really well as long as I'm, making sure what you need is there. Cardiac and respiratory are your basis for nursing, I think. I think especially respiratory. So respiratory distress, heart failure will be always some things. Cardiac, whether it's adult or children, right? So I'm going to go into it, try to explain it for you so that you're okay with it. And there's like 32, 34 questions. So be out, good time tonight. You can enjoy your Friday night. One of your classmates just went off to get her daughter married. So I'm happy for her. I said, no, get out of here. You're not allowed to stay in class. You've got to go watch your daughter get married. How many teachers tell you that? You're going to
No.
miss time, but you got to go. It's something you'll never get back. You got to go.
658.
All right. Everybody ready?
Not yet. 1 second.
Okay.
I'm almost there.
That's all right. Not a problem.
I'm all ready. Thank you.
You're very welcome. Here we go. So respiratory and cardiovascular. And there are differences in the hearts. Acute coryza is another name for just a definition. We do give you a lot. First page in your study guides, always all your definitions. Now, these you should be looking at definitions, your vocabulary for each chapter. Those things you're going to see over and over again. Coryza is a common cold. Simply a common cold. You won't forget that one now. Acute croup is also called. Now, croup is upper airway, and it has to do with swelling. Ever hear a child barking like a seal? This is acute croup. It's all about can't breathe the air in because it's all swollen. It's also called laryngotracheal bronchitis. Again, the larynx, the trachea, the bronchus, all this upper stuff swells. And then there's this barking cough, very distinctive. That term is used describing the collapse of an alveoli. At the end base of the lungs, where air exchanges, are called alveoli. They exchange oxygen and carbon dioxide. Now, when you post-operatively, you don't cough, deep breathe, they get clogged, they collapse. What is that called? And it's called atelectasis, right? That's why we teach our patients, get out of bed, cough, deep breathe, use incentive spirometry. That's why we do that, because we want the exchange of oxygen and carbon dioxide. Let me make sure that I did one thing. Nope, I did. I always have a fear that I'm going to not have on my recording. And then at the end, I'm struggling to get it to you. Thank you. All right. What is tachypnea? Remember, tachy is always what? Remember, you'll see tacky, you'll see Brady. What does that
Tacky is
mean?
fast.
Yes, you're tachycardic, you're tachypnic, you are fast. Tachypnea is respirations. Tachycardia is with your heart rate. Dyspnea, DYS, is anything that's difficult, the breathing, okay? So that's why I threw it in there because some people had answered that. What will the nurse teach the child with cystic fibrosis to take to facilitate digestion of her nutrients? Now, cystic fibrosis is a condition that affects lungs and it affects the small intestines. Specifically, the pancreas does not secrete enough enzyme to digest fat. So this child is having a problem with nutrition because fats are really high in calories, right? So cystic fibrosis is usually diagnosed at birth. What we'll do is something called a sweat test. And it's just a little electrode goes on the skin and we measure sodium. Now, the levels are sky high. You're losing salt like crazy through the pores. So now you know you have cystic fibrosis. When these children eat, they cannot digest fat. So these children will have a hard time digesting fat soluble vitamins. They also will have a problem digesting fat. So you're going to see these foul smelling, bulky stools in it. And of course, what are we going to do to help these children eat? Fat is the highest of all the calories in, the dietary. Carbohydrates and proteins are 4 calories per gram. Fat's 9. So what do? High fat, high carbohydrate, high protein, high carbohydrates, and they need salt. So don't take the salt shaker away. This is one case, give them the salt shaker, okay? Pancreatic enzymes are given orally or sprinkled on the food immediately before they eat, and it helps aid in that digestion.
I have a question.
Sure.
So you say to test for CP, right? It's a
Cystic fibrosis,
right, and they
CF.
check the sodium level, but they also need sodium in the diets.
Well, if they're losing it through their skin, they
Oh,
do
so it's
need extra,
excess
right?
sodium.
They're always sweating it out. It's not just for the test that shows, it's all the time. They're always oozing salt. If you lick the skin of a CF child, it would be salty. And
Okay,
I've told parents, Dad, lick it, see what you see. I'm not going to lick the child's skin, but a parent could, and they would taste salt, and it's quite large, actually.
okay, all right. Thank you.
You're welcome. When a child has a fever and an upper respiratory infection, what should be included in the nursing care plan? What do you think? A fever, upper respiratory, got a cough. What's going to help here? We know that fever, we're going to medicate because you don't feel good when you have a fever, whether it's acetaminophen or ibuprofen. Also, remember, fevers lose a lot of fluids, so small amounts to prevent dehydration. Dehydration in children is dangerous. It's the one thing we can prevent and we need to be aware of. You have a fever, offer extra fluids. Asthma causes what? Children with asthma, what is our concern? We know asthma is air gets trapped in the lungs, and they have to wheeze hard to get it out. You're coughing, you're retracting to Kipnick. I mean, we know all these things happen, but many children get it. There's some sort of allergy that caused it. And these are things that happen. They have to go to the doctor more frequently, right? Probably need some steroids to help them feel better. They're not going to school, increased school absenteeism. Sometimes that asthma, that barking, just a little bit of steroid at home is not working, they're admitted. Injuries has nothing to do with it. It's all that extra time in hospitals, doctors, and missing school, okay? What is the most common reason for pneumonia in infants? What causes it? What do you think? And it's the respiratory syncytial virus. Ever hear of RSV? RSV gets in and goes into the lungs and then causes pneumonia. Again, it's viral. So RSV, which is a virus. Rest, fluids, antipyretics. Antibiotics don't work on viruses. So rest, fluids, and the antipyretics. Which congenital heart defect causes increased pulmonary blood flow? Now, what and how would you know this? Well, we have a four-chambered heart, and the right side, it comes back from the body and it goes through the right side up into the lungs, right? What would have to happen to get more blood there? Well, if there was a hole between either the upper chamber or the bottom chamber, that would put blood from the left side, which is just back from the lungs, over the right side, and it goes back into the lungs. Also, there's something called a PDA, and that's fetal circulation, and that connects the lungs to the body. So again, that can go back to the lungs. So increased blood flow, there has to be a hole from the left side that's going back to the right. And it would be either your atrial septal defect or your ventricular septal defect. A child swallows frequently after a tonsillectomy and an adenoidectomy. What might this indicate? What do you think they're swallowing? What's happening here? And this would be something postoperatively you're going to teach parents to look for. And it's bleeding. You see him swallowing, it's blood. Well, think about where your tonsils are in your throat. Do you know how they remove them surgically? They take a scalpel and they just cut them off and then cauterize the area and make a clot. So basically, there's two scabs for the tonsils, and then whatever the adenoids, how many there could be several on each side. There's another more scabs that have been formed there, and they can, just like a scab on your knee or anywhere, can lift up and it can bleed. It can actually bleed so much that these children go into shock. I've seen it where a 7-year-old was bleeding. She had just come from the doctor, and on the way home, she vomited lots of blood. What did we do? Well, we sent her back to the OR, brought her into the ER, gave her fluids, got her heart rate back where it had to be, got her blood pressure where it was. She got much more alert when she had a better blood pressure. And then we got her up to the OR and they just cauterized it again. Signs and symptoms of respiratory distress. Now, this can be in children or adults. This is one of those big concepts. Respiratory distress, what would I see? Well, you're not getting oxygen to the brain, so confusion. No oxygen, the brain don't work. The lungs, any breath sound, wheezing, rhonchi, rales, any of those you're going to hear. Then you're in distress, you're trying to breathe faster to get oxygen. So tachypnea, but you'd also see tachycardia, again, trying to get the oxygen around to the cells. Actually, bradycardia is the last stage of respiratory distress, and they're about to have a code on you and they're stopped breathing completely. So, respiratory distress, when they're bradycardic, make sure the doctor's there right next to you. What is an acceptable oxygen saturation for a child? What would we accept? Does it have to be a perfect 100? And what they say with children is above 90, it's fine enough. 85 is getting a little lower. By 85, we'd put a little bit of oxygen on that child, whether through a nasal cannula. That's a little bit that they would need. 80 is way too low, and that would require even more support, maybe an oxygen mask. A parent of a 3-month-old child with cystic fibrosis wants to know how the child got the disease. Neither the parent has cystic fibrosis. Well, cystic fibrosis is inherited, and it's actually the same as sickle cell disease. Two parents have the trait, they carry it, but they don't have a disease. If both parents have it, each child has 25% chance of getting the disease, okay? So both parents have to have it as a trait. They carry it in their genes. And then 1 out of 4 chance this child's going to have cystic fibrosis, the disease.
It doesn't matter if the parents or if the child is a mixed race, right?
No.
Okay.
Which fluids are most appropriate for a 5-year-old with asthma experiencing dyspnea and fluid loss? So they need to drink, right? Again, with any sort of extra breathing, your mouth is, getting rid of fluids too. We need to replace them. If we can give them orally, what's the best? And it is room temperature water. I've had a breathing episode where I had the room too cold, and it precipitated me from started to breathing like that. Once I turned the temperature back up, I was good. Same thing, temperature, same thing, water. Always room temperature is the choice. Any patient with dyspnea, not breathing good. How long after a smoke inhalation injury are patients at greatest risk for pulmonary edema? So smoke inhalation, drowning, they're actually the same when it comes to time where you worry about the lungs saying, I can't do this anymore. I've had this attack of smoke, or I've had water in my lungs. I don't like it. And it's 72 hours. Why do you think children with smoke inhalation will admit them for 3 days in a monitored area, monitoring their oxygen saturations? Same thing with drowning. I mean, the rescue comes, the kid's up and already, walking around. They say that he doesn't need to go. And yes, he does. 3 days later is when we're out of the clear. So they could go into respiratory distress in that time frame. What findings are expected when measuring the blood pressure on all 4 extremities of a child with coarctation of the aorta? Now, what is coarctation of the aorta? We know that the aorta comes off the heart, goes over this round called the arch, and goes to the body. A coarctation is a kink, a narrowing, a stenosis. Blood can't flow down to the feet the way it should, right? A kink, blood can't go. So you're going to see lower blood pressure down below because blood can't get there. And because the blood has to go backwards, the upper extremities are going to be higher. sometimes as a nurse, I found one coarctation in my career, still remember it. I couldn't feel pulses. Dorsalispedia, posterior tibial on a brand new baby in the newborn intensive care unit. And I then took blood pressures, and it was 20 millimeters of mercury difference, upper and lower. It was classic. So you too, as a nurse, can find these things before even doctors find them. What type of diet should a child with cystic fibrosis be eating? So remember, cystic fibrosis is the lungs don't work good. We need good pulmonary care, CPT, aerosols, etc. But we also need pancreatase enzymes to help digest food because they don't digest fat. So we need a diet that is good, high in protein, high in sodium, and carbohydrates. Give them all of the calories we possibly can. So never high in fat. We don't worry about fiber. With all of that fat, you're having bulky loose stools. You don't need any extra. And we do need the sodium. So good job. Blood flow between the vessels of the heart. When it goes from like this increased pulmonary blood flow, when it goes from the left side and crosses over into the right side, what is that called? And it's called a shunt. Now, let me tell you what atresia and stenosis is. Remember A, like apnea, A is nothing. Nothing is moving. There's no blood flow. Atresia, that actually is when the valves don't work, like the tricuspid valve between the right side. That's tricuspid atresia, no opening. And then we have things like stenosis, a narrowing. Blood still gets through, but it's narrower than it should be. And usually, if it's in the heart, in a valve, we have to open up that valve so it works better. That's a stenosis. So shunt is the blood flow. Atresia, nothing's moving between those areas. And stenosis is a decrease because there's a narrowing of the vessel. What is an atrial septal defect? By what I've said, what do you think it is? So atrial is the upper chambers. Septal is the septum, that division between the right and the left side. So it is an abnormal opening between the upper chambers. So what would be a ventricular septal defect? The lower chambers, there's an opening between them. Usually we see VSDs in your Downs children. One of the most common of all with Downs and congenital disease is the ventricular septal defect. And you hear a that's the murmur. Instead of choo, 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 you hear, and depending on how large it is also. Why do children with tetralogy of Fallot favor a squatting position? Now, tetralogy of Fallot is that one diagnosis you need to look up. I have found it's the most tested on NCLEX and HESI. Like, what is tetralogy? It's when the pulmonary artery closes up and blood can't go to the lungs from the right side. So most of these are fixed when they're younger, but there are older children that have it, not fixed yet. And what they do is they fall down on their knees and they squat, and it just changes pressure between the abdomen and the chest, and it increases that return of blood flow, and it pushes open that closed area. Normally it's open, but then all of a sudden, like a piece of tissue or it goes into spasm, something happens and it clamps off. I had one baby. His name was Nolan. I'll never forget him. At 4 in the morning, I was just fixing him up a little bit, washing his face, changing his diaper. and he went into a TET spell, that blue spell it's called. And he went from a saturation of 100% to a saturation of 10 in about a minute. He went from this pink baby, he was blue black. It was very quick and very intense to see him do that. So I put him in a knee chest position, mimicking the same thing. Which comment by the parent of a 1-month-old infant would concern the nurse about a possible congenital heart defect? Well, if you have a congenital heart defect, let's think. Heart's not working right. Blood's not pumping the way it should. Maybe oxygen isn't pumping the way it should. What would you see? You're not getting oxygen around and nutrients to the body. Well, he's going to be tiring out when he's eating. And this child, because he tires out because he's eaten, when he's eating, he doesn't finish it, he's not going to be gaining weight the way he should. All of those things are hand in hand. So how would we treat this child? That'd be another thing. So we would do frequent, shorter time feedings. And also, we would increase the calories in the formula or the breast milk so that infant gets the calories they need with smaller volume. Okay. What does a nurse explain that a ventricular septal defect will allow? What does it do? So here we've got the word shunt in there. So we understand what that word shunt there means, right? So we know the heart, the right side, the blood just gets back the blood from the body, right? So pressure is very low on the right side. Remember that. And we know the left side is getting all the blood from the lungs. It's actually 4 pulmonary veins that goes from the lungs to the left atrium. So there's a big flow. So shunting always goes from higher flow to lower flow. So we know that it will go from the left to the right. Okay. And it's oxygen still getting there. So it's not a problem with that. It's going to cause it to be recirculated in the pulmonary system, but you're still with a good oxygen, so it is okay. So shunt left to right and increase pulmonary blood flow, and the kid's O2 saturations are going to be 100. Kid looks good. This has a noisy sound in his chest, right? That murmur. What is a non-invasive procedure to determine if a heart is structurally normal and to find a murmur? So an electrocardiogram is an EKG. That shows you the rhythm. It shows you, are you beating the way you should, a normal sinus rhythm, or are you tachycardic or bradycardic? All of these things show there. An echocardiogram is like an ultrasound. You can look in and see the way blood flows and look at blood vessels, and you can look at the valves, all of those things. So an echocardiogram is just like an ultrasound. They rub it on top of the heart and they look at it, and it's really looks at the structure really closely. Rheumatic fever causes which inflammation? Now, rheumatic fever is when you don't treat strep completely. So it causes something that you'll see maybe 3 weeks later, 4 weeks later. You're going to see all of a sudden polyarthritis, a rash. You're going to see this weird, awkward movement in the arms that you can't control. But the worst, or the one thing that's harder to cure, is the inflammation in the heart and the possibility that a valve is going to be destroyed, literally. So carditis, chorea, polyarthritis. So how do we treat rheumatic fever if it's due to a strep infection that wasn't treated completely? We're going to give long-term antibiotics. Okay. We also give monthly penicillin for up to 5 years to keep it away. Okay. So after recovering rheumatic fever, they need to receive monthly injections of 5 years of what medication? What do we give strep? That's the answer, right? And it's penicillin. Prednisone is an anti-inflammatory. A steroid. We don't need that. Rheumatic fevers due to a strep infection, we need an antibiotic, and that is penicillin. And then we'll give it every month for 5 years to keep it away. What life-threatening illness is caused by H. influenza that causes swelling above the vocal cords? These upper airway is swollen off and you can't breathe. Air does not go in. And this one is called epiglottitis. Now, it starts with laryngeotracheal bronchitis. And if we don't treat that swelling with a steroid, whether a shot, whether 3 days worth, once a day, twice a day, steroid, it will progress. And then the whole epiglottis gets swollen and it's covering the trachea and you cannot breathe. So, what is our big concern? The trachea is covered, air's not going in. You don't have an airway. This is when you make sure that you have an intubation tray or a tracheostomy tray at bedside. These children can't get air in. We have to do something to help them. The nurse should prepare for emergency intubation when caring for a child with what diagnosis? And it is epiglottitis. Okay. You really try not to intubate asthma. Once you intubate a child or an adult with asthma, it's extremely difficult to get that intubation tube back out. So it's not asthma. So I wanted you to know that for sure. Epiglottitis, there's no airway. So we got to do something. Intubation and sometimes even a trach because you can't get the tube down. The epiglottis is covering the trachea. I can't get the tube in there anywhere. How do you treat primary hypertension in a child? Years ago, we didn't even take blood pressure on younger children. And we've learned that some of them have high blood pressure and they were getting issues like kidney disease, right? Which is part of hypertension. So, what do you think? The easiest way is we'll just put them on a DASH diet. We'll make sure that they have fruits and vegetables and fish and chicken, and we'll be careful with our salt. And that's usually all they need. And of course, just regular activity, nothing crazy. And that usually will help before we even consider giving any medications at all. Okay. And of course, the activity they do, you don't want something that stresses them. So something that's more in the moderate area. What congenital heart defect is diagnosed with an aortogram? That aortic arch in the aorta. What did I tell you? What was the name of that one? I described it to you. And an aortogram is when they put dye in the aorta to see is it open, is it patent, or is it kinked? And the answer is coarctation in the aorta, a kink in the aorta. So they put the dye in, they see the kink, and only a little bit of dye goes below. Coarctation of the aorta. So tetralogy you need to know, coarctation of the aorta. Those are two of the ones that you will see questions, even onward to your NCLEX. Early signs of congestive heart failure. Your heart is weak and it's not beating the way it should for whatever reason. What are you going to see? Because it's the symptoms we see before we diagnose congestive heart failure. So it's our eyes and our assessment skills that help us diagnose. So congestive heart failure, your heart's not beating properly, blood's not getting to the kidneys the way they should. It's filling up the lungs with fluid because it can't squeeze it all out, and you're going to see a weight gain. And it's usually a rapid weight gain, at least like a 3/4 of a pound a day. That's a lot on a little 6-pound baby, right? Remember, congenital heart defects are brand new babies. Also, these are the children because they're huffing and puffing and they can't breathe. They're going to tire easily when feeding. They're going to be dyspneic and even asleep. Their heart's going to keep trying to work fast and it's going to be tachycardic at sleep. So all of them. What is the difference of cholesterol, HDL and LDL? I always remember them. HDL is healthy cholesterol, and LDL is lousy cholesterol. So HDL reduces the risk, LDL increases. As simple as that. Hyperlipidemia is what? What does that mean? So too much fat or fat-like substances in the blood. This could be high cholesterol levels is another word for it. Last question. Hypoplastic left heart syndrome involves the underdevelopment of what? Well, look at what the name of the syndrome is. This is probably the most severe of all congenital heart defects. The left ventricle is big and thick in the small little area inside and it doesn't pump. So your engine for the heart's not working. This is a cyanotic heart disease, and it is the left ventricle that's not working. It's not built up the way that it should. All right. Andrea, good job. That's a good comeback. Trish, number 2. Number 1, 17154. And Katie and D. So that's what I have for today. We're going to be doing our exam analysis tomorrow. I believe it's at 1:30. She has it scheduled for. So I'll be posting those grades. So anybody who wants to know their grades or see what they got wrong, just let me know. We can meet. We could go over those. If I see that you're missing a bunch of math, I'll reach out to you to tell you. But all in all, only one person was borderline. The rest of you did amazing. So good job, class. Great job, Giovanna. I'm a proud mother here. I'm so proud of you. That was a great 98. That was awesome. So have a great weekend. If you need me, I'll be here for you. Okay. Have a good
Professor, I
one.
just wanted to talk to you if you don't mind.
Sure.